I'm very pleased to ask John Saville to give the Bland Sutton lecture. John is a very distinguished physician and clinician scientist. His original work was in inflammation and renal disease. When I first met him, he was Professor of Medicine in Nottingham, and shortly after that he moved to Edinburgh to lead a very successful inflammation group in Edinburgh. And then with a meteoric rise in career, became, I recall, Vice Principal, and now is the Chief Executive of the Medical Research Council. I'm very pleased to ask him to come and speak on the future of clinical research. John, thank you.
Thanks, John. I'm sorry I'm a disappointment to everyone. I've got good reason to be very grateful to surgeons, however. My elder son, more of whom recently, in a minute, recently presented with a ruptured appendix, and his life was saved by surgeons at a hospital in London, so thank you for that. And also a couple of weeks ago I discovered that I was only the 5th physician ever to be made an honorary fellow of the Royal College of Surgeons of Edinburgh. So I'm not a complete imposter, and what I hope is that clinical research is of interest to an academically orientated group like the Association of Surgeons. I'm not going to go on for too long, and I'm not going to go on about anything very technical, because I think the future of clinical research really is defined by a set of simple behaviours that what I want to do is encourage you to engage with. Now, as John said, I'm currently serving at the MRC. We're 99 years old this year. That's our mission as enshrined in our Royal Charter. But following the comprehensive spending review, in which public spending on medical research was threatened with a 25% cut, but thanks to our friends escaped unscathed, there's another bullet point on that mission, and that is that MRC must work with industry to drive economic development. And I go further, most of the people in this room spend public money in one way or another, and I'm afraid we're in an era where if we're spending public money, we have to think about how that will promote economic development in our country. Now, many of us, particularly those of us in teaching hospitals, live in this triangle where service, teaching and training and research are indivisible. And I think if we get that right in the UK, we won't just secure benefits in health, we'll also drive gains in wealth, more of which in a minute. Now, because my wife isn't here, I can admit that I'm really only interested in two things. One is medical research and the other is cricket. And I'll explain why I've got this picture of England's current cricket captain a bit later in my talk. But if anyone looks me up on Wikipedia, they'll find that my entry has been doctored by my son, who was a professional cricketer. And he refers only to an innings I once made when my team won a low-scoring match, and I carried my bat for 3 not out off 83 balls. And I'll come back to why that's really important for a clinical researcher in a minute, because it really is a long game. It's like cricket. Now, as a registrar, I got very interested in why inflammatory conditions sometimes resolve completely. And because no one understands kidney pathology, I brought a good example here, pneumococcal pneumonia. Even before antibiotics, it resolved completely in many cases. Billions of neutrophils infiltrating the alveoli were cleared completely. What was the mechanism? I was very lucky at the Hammersmith Hospital to bump into a young doctor called Chris Hazlitt, who discovered what happened to the neutrophils in resolution of inflammation was that they were eliminated by a process called apoptosis. I won't go into that. And here is a figure from the first paper I wrote on this. It's joint fluid from a patient with seronegative arthritis. And what you see is you see neutrophils undergoing apoptosis and being eaten and destroyed by macrophages, a phenomenon rheumatologists had actually recognized and called the writer's cell. Here's some data. I won't talk you through it. I promise not to be technical. But this is work many years later from Adriano Rossi in Edinburgh, which showed that certain drugs originally designed to treat cancer, inhibitors of cyclin kinases, quite unexpectedly promoted the resolution of inflammation that was otherwise destined to cause loss of organ function and death. And what I want to get across is that in my own career, driving the resolution of inflammation, it's taken ages. The original observation just before I started my MRC clinical training fellowship was 1985, and we're still only just in patients in 2010. And that's really why I want to get across the idea that clinical research is a long game, because this is Andrew Strauss raising the ashes in 2009. And the reason England won that series was in the first match at Cardiff, our last pair batted for hours and hours and hours and would not give in to the Australians. We drew and we won the series. And that, for me, is the metaphor for clinical research. We have to really commit to it and stick to it and work hard for years. Otherwise, our patients don't benefit. Now, these are the behaviours that I'm going to refer to. I won't go on too long, but the first and most important is nurture the seed corn, and it's great that there are lots of young people in the audience. As John said, I arrived in Edinburgh late in 1998. I walked into an office. All it had was a waste bin and a telephone. That was the University of Edinburgh in those days, you know, thrifty. And the phone rang, and it was Mark Walport at the new Academy of Medical Sciences who said, we want to do our first report. It's got to be on academic training. And this was the outcome of that work. And one of its recommendations was that we should actually count the number of clinical academics in the country. No one had ever done it before. And what I discovered when we did that was that we had the same number of clinical academics as there were pilots in the Battle of Britain in the RAF, around about 3,000. And what ensued over the next 10 years really was a medical academic Battle of Britain. And if you look at this graph, you can see that particularly the young pilots, the clinical lecturers in green, were being lost in action at a very alarming rate. These posts were being disestablished, academic numbers were falling. It looked like within a decade the discipline would be dead. And at last, the cavalry arrived largely in the shape of Dame Sally Davies, who responded to the Walport report by introducing NIHR clinical lectureships. And you can see now that the trend in all the curves is upward again, which is great news, I think, for patients who benefit from the research that clinical academics do. And here's the integrated training program that Mark Walport proposed in his report around the time Modernising Medical Careers was implemented. It's working extremely well and is strongly supported in all 4 health economies within the UK. And the MRC plays its part by funding doctoral training fellowships, clinical research training fellowships, about 50 a year, and clinician scientist fellows, about 15 a year, young individuals who are doing postdoctoral research, working towards independence, and then the very best people undertake senior clinical fellowships. And here's the picture for surgery. You're right down at the bottom, but that doesn't mean that you aren't the most important. So this is a survey that was undertaken in 2009. On the left are the number in England of pre-doctoral academic clinical fellowships. Young people fresh out of foundation, doing general specialty training in an academic job, and you can see the largest number of them are in surgery. And furthermore, the bar cardiologists who've got their own £100 million a year charity, the British Heart Foundation, the largest single group of people with clinical training fellowships were young surgeons as well in 2009. And indeed, if you go further and look at the postdoctoral landscape, surgeons outnumbered virtually everybody else in terms of clinical lectureships and didn't do so well on this data in these highly sought-after postdoctoral clinical research fellowships, but this was English data. I'm still head of the medical school in Edinburgh. I'm delighted to announce that even in Edinburgh we've got 5 more surgical clinician scientists to add to that 9 identified there. All these people will be professors very quickly. So I think the future looks very bright. But it's a long game. These people have got to commit themselves to a career pursuing clinical research if we're going to make a difference. Now, a crucial thing is to understand the value of research to the NHS, and that's tough right now, given the pressures on the service. And I want to spend a bit of time on this, because I spent time as a clinical director for research and development at the Queen's Medical Centre in Nottingham. That secured my interest in clinical R&D. I spent 3 years as grandiosely titled Chief Scientist at the Scottish Government Health Directorate, the steward of the R&D system in Scotland. And I've referred to the triangle before, and it behoves us to remind our colleagues in the NHS, throughout the NHS, how valuable R&D is. Because without it, we won't develop improved prevention, diagnosis, or management. And I often think about my first 2 house jobs. My boss as a house physician was thought to be revolutionary because he didn't sedate people with myocardial infarction for 6 weeks and keep them in bed and let them die of venous thromboembolism. He was actually revolutionary in that he kept them in for only 10 days. Now, if you have an ST elevation MI in Edinburgh, it's diagnosed telemetrically in an ambulance, you're brought for primary coronary intervention, you're home within 24 hours. Revolutionary change. My next job as a house surgeon, my boss was an expert on highly selective vagotomy. I'd like to know when the last highly selective vagotomy was done in the UK. Tricky operation, lots of side effects. Now we know that a few antibiotics will eliminate the cause of peptic ulceration, Helicobacter pylori. So very expensive, dangerous practices eliminated by research and development. And I really think that the business of our colleagues in NHS management should be inculcating a culture of continuous improvement based on evidence. And I think research in a hospital recruits, motivates, and retains staff. So it's a great thing to have. MRC chips in with all kinds of research that informs guidelines. Here's a piece of research which shows that if your hospital is entering patients into any sort of trial for cancer therapy, all the patients with cancer in the hospital benefit. It's quite remarkable. Don't know what the mechanism of that spillover effect is, but simply thinking hard about patients, and I'll show you another example of this spillover effect in a minute, is beneficial. So I think R&D is a good thing to have in our system. And while in Scotland, I became really excited by the power of data and the ability to link data. And in England, that will now be possible thanks to investment in the Clinical Practice Research Database that will be held at MHRA. In Scotland, it's been routine for many years. And I want to show you an example of the Scottish Clinical Diabetes Research Network. If you're diagnosed with diabetes in Scotland, you are immediately invited to join the database. You're consented for future research. Every single patient with diabetes is on that database. All their blood tests are available. There's 186,000 retinal photographs stored. And what's really great from the point of view of a researcher is that the NHS has realised how valuable this database is, and it's now secure in the NHS data service in Scotland. It's paid for by the NHS. And one of the reasons of this, I brought the wrong slide, apologies, is since this data was set up, there's been a 40% reduction in both blindness and amputations in Scottish diabetes patients without any particular intervention. It's simply collecting the data and benchmarking it against your colleagues has made an enormous difference for patients. Here's another example of the power of this data linkage. Those of you interested in cardiovascular disease will remember the WASCOPS trial, the West of Scotland Coronary Prevention Trial, one of the very first statin trials. This is Ian Ford. The first trial probably cost $30 million. He got a paper recently in the New England Journal of Medicine that probably cost £30,000. But what it showed was a 15-year follow-up of the patients who'd been treated. There was still persistent benefit. You couldn't do that in any other country in the world at the moment. Find the patients who were treated with a trial drug 15 years before. You'll be able to do that in England. You'll be able to follow every patient that you've ever operated on, provided a unique identifier is available. It's going to be an enormously powerful resource, not just for research, but for improving clinical standards and outcomes. Now, another thing I was really encouraged by today was I was speaking earlier in a seminar run by the Surgical and Academic Research Society. And many people, I think, have besmirched surgeons unfairly as natural loners who love doing things their way. And I was delighted to hear that groups of surgeons around the country are now coming together to form networks that undertake really important trials and other studies, because collaboration is crucial now, not just between investigators, but between disciplines. Now, this is the Queen's Medical Research Centre that I work in Nottingham. It's in, well, that's a slip, isn't it, in Edinburgh. It's been there 6 years, £70 million, all raised externally. It contains a state-of-the-art clinical research imaging centre, and 3 research centres, each of which feed off each other. One in inflammation research, one in reproduction, one in cardiovascular. It has young surgeons working in the building. We've got clinician scientist surgeons interested in reperfusion injury, in liver surgery, in chronic rejection of both kidneys and livers, and another surgeon who has funding from the GlaxoSmithKline and the Academy of Medical Sciences to pursue a new target in severe acute pancreatitis. And the point I want to get across is that the advance of medical research, and this is very much the bench to bedside end, relies on groups of people from different disciplines working together. The young surgeon I referred to with the GSK project is working with a chemist, he's working with a radiologist, and with an inflammation biologist. Now, lastly, what's really important in collaboration is to get institutions to work together, and this was what was great about this surgical network I heard about earlier. Here's an example of how some big institutions in London are going to change the game in fundamental research in medicine. This is the Francis Crick Institute, £700 million capital project. We'll spend £120 million a year on understanding human biology and how that informs on disease, led by a Nobel Prize winner. Wouldn't have happened without collaboration. And here are some recent centres that the MRC established in musculoskeletal ageing. 2 centres, 5 universities, 5 cities, lots of hospitals. This is the future. We have to learn to collaborate to get the maximum out of our research. Now, I'm very close to finishing, but I mentioned the importance of working with industry, and I think surgeons in particular have a very good record of working with industry because, as I observed earlier, you have the advantage over physicians of very often you can handle the pathology that you're dealing with, and you can often ameliorate it with devices. And, of course, the industry exhibition is almost completely about devices. So perhaps I'm preaching to the converted, but for me as the head of a medical school, this report in 2006 changed the game for me. It's from Sir David Cooksey. It was about the translation of research into patient benefit. It identified 2 gaps in translation, one which is now very much the business of the Medical Research Council, that's the bench to bedside and back again gap. Another, which is now very much the business in England of the National Institute for Health Research, a wonderful thing, £1 billion budget crafted by Dame Sally Davis. It's a fantastic achievement, and that now is focusing on larger scale studies and the issue of how you might get things from campus to clinic. That is how you get research adopted within the NHS. This is a really, really important piece of work. and MRC responded and was funded by government with a whole slew of funding to promote both commercial and clinical translation, and I won't bore you with the detail. Now, finally, I want to emphasize how important it is to get organized. I'm going to refer to the Academy of Medical Sciences. I was one of the founding fellows of this. I wouldn't get in now. I'm not sufficiently distinguished. Just a decade of this, and it's done amazing things. Thanks to the work it's done, we now have an integrated academic training pathway. I've shown you that across the whole of the UK. We've now got increased recurrent funding for clinical research. I've referred to that. We have probably the best clinical research facilities in the world, certainly comparable to those in USA, far better than any other developed nation that I've visited. And most recently, we've had the bureaucracy-busting regulatory review from the Academy, which has been accepted completely by the government. And in England, you're going to have the Health Research Authority, which hopefully will be a one-stop shop for facilitation of research. So, to conclude, for me as a clinical academic, this is the way forward, is to think in terms of the benefits of service, teaching and research. They feed into health and wealth gain. There's the list of things that I hope you might consider doing. Nurture the seed corn, understand the value of research to the NHS, learn to collaborate, think about health and wealth gains, and get organised. And I'd just like to acknowledge some of my mentors, and mentorship is crucial here. Chris Hazlitt is Professor of Respiratory Medicine and Director of that Queen's Medical Research Institute in Edinburgh. He was my PhD supervisor. Keith Peters gave me my first job in academic medicine. Peter Rubin appointed me to be a Professor of Medicine when I had 2 papers and I was 34, and he's now gone off to run the GMC and worry about standards. Colin Bird was the visionary dean at Edinburgh who attracted me there, and David Carter, who was Chief Medical Officer and Regis Professor of Clinical Surgery in Edinburgh, has been an enormous help with chairing the Board for Academic Medicine in Scotland, and I've been lucky enough to be funded both by the MRC and the Wellcome Trust. So I'll stop there, John. I imagine this isn't a questions lecture, so thank you very much.
John, thank you very much. It's the tradition of the association that the Vice President thanks the Bland Sutton Lecture, and I'm very pleased to do this. John, one of your colleagues in Edinburgh said of you that you had the ability to make things happen seemingly without effort. And I think it would be true to say that as surgeons, and particularly as academic surgeons, we have a lot to thank you, Mark and Sally, for, in that the initiatives that you've described have absolutely transformed academic surgery. In the audience are a number of academic clinical fellows who are producing very high-class, high-quality science. We also have clinician scientists here who would not exist but for these initiatives. And after 20 years as a senior academic, I finally got clinician scientist post from the MRC. So thank you very much. I pity it wasn't maybe a bit earlier, but nonetheless, I'm very grateful. One thing I would take issue with you as someone who really quite liked highly selective vagotomy. It's a really nice operation, and contrary to what you say, actually doesn't have a lot of bad side effects. But in fact, I can't believe that there is anyone who still does these. So thank you very much for giving us this lecture and at very short notice. I notice it's 99 years of the MRC. It's also, at the moment, 99 years of the British Journal of Surgery. And at the next meeting next year, we're certainly going to celebrate the 100 years of the BJS. And it seems to me that it would be very nice if the MRC might also contribute to that meeting in celebration of their centenary. So we perhaps look forward to seeing you again. So thank you very much.
Ladies and gentlemen, can I welcome you to the hot topic session? The ASGBI has had a hot topic session for the past 4 or 5 years. The topic is deliberately chosen to be provocative. Usually we find that there's quite a lot of common middle ground. Today's topic is the only way to deliver emergency surgical services is the creation of a general GI surgeon. Now, we've deliberately put the word general in there because we know some people feel very strongly about it for and some very strongly against it. Excuse me. We have 4 very, very prestigious surgeons to argue for and against this motion. We have Mr. Bill Allen, who's recently demitted as chairman of the General Surgical SAC and is shortly to be president of the Association of Upper GI Surgeons. Seconded by John Moorhead, who is the Honorary Secretary of the ASGBI, consultant surgeon in Belfast. Speaking against is the eminent Michael Parker, and well-known general laparoscopic colorectal surgeon, previously president of the Association of Coloproctology, and president of the Association of Laparoscopic Surgeons, president of many other things, I've no doubt, Mike. The deviation from normal for this debate is where you can tweet questions, which is an idea we've pinched from the Association of Coloproctology. So you're invited to share your thoughts, and what you do is you tweet using the hashtag, which is up there. And what happens is that when you tweet it, there's a man behind a curtain in there who receives them all. So if you send abusive or insulting tweets, they get deleted before they're brought up on here for me to see. So there's no point in sending out rude messages for me at this stage. If you haven't got the topic in front of you, it's on page 11 of your program. The only way to deliver emergency surgical services is the creation of the general GI surgeon. So just to start the debate, can I have a show of hands, please, as to those of you now who feel that that statement is correct? The only way to deliver emergency surgical services is the creation of a general GI surgeon. Hands up who agrees with that motion. Perhaps our Chief Executive would just glance around there. Are you around, Nick? There. Okay, and those of you who are against that motion? A clear majority, I would say. And those who are undecided or abstaining. Everybody's got an opinion. Well, I suppose it is a group of surgeons, isn't it? So with that, could I ask Bill Allen to kick off? Thank you.
Thank you, Mr. President. Fellows and guests, I'm here to propose this motion, and John Moorhead is here to second it. And what we're going to do is I'm going to set out the background to this and try to demonstrate you why we think it's an appropriate way forward, bearing in mind a lot of changes that have been going on latterly. 5 years ago, this association held a consensus conference. It was very well attended, and it produced a widely circulated document. And this was one of the statements from it. Harold Wilson said that a week was a long time in politics. 5 years in surgery probably is a much longer time, but nevertheless, we think it's time that this was revisited because of the changes that have occurred in the last few years. Let's start with an anecdote. A few years ago, my 78-year-old mother developed a sigmoid colon carcinoma. She lived in Oxford. From the medical background, I knew exactly who I wanted her to be looked after. And Neil Mortensen very kindly took her over and expertly managed her. About 4 years later, she was visiting my brother, who's an orthopaedic surgeon, lives in Windsor. She developed acute intestinal obstruction. She was admitted to Wexham Park Hospital, and Andrew Gordon performed very expertly an appropriate laparotomy, and she unfortunately developed a degree of biochemical imbalance and some psychological disturbance, which the team managed expertly. And I think that anecdote gives an idea of the issue we're looking at. You have, on the one hand, the specialists looking after the elective work, and on the other hand, the generalist taking on what's coming in through the front door of the hospital on a 24-hour-a-day basis. I'm breaking my presentation down. I was thinking at first to do it purely as a talk, as is a debate, but I felt that I had to try and put it into some structure, and it's going to be easier for me to put it into some slides. We've got to address patient expectation, which I think is probably number one on the list. And the experience of that anecdote, and all patients' experience, they want to be treated by a specialist, somebody who knows what they're doing and can do it expertly. We're moving into a world already where there's an enormous amount of information that patients can get access to. We book our holidays online. I dare say many of you booked your travel coming here online. And I suspect before too long, patients will be booking their medical care online, looking up each and every one of us to see how good we actually are in our specialist world, mainly elective. But I don't think you can be eligible for choose and book when you get peritonitis. The emergency situation, I think, is a completely different issue. As we heard yesterday, it's been added on to many people's practice, despite the fact that Ian Anderson's survey clearly demonstrated that 3/4 of consultant general surgeons who responded have a significant part of their working week involved with emergency activity. And that's up and down the country. And if we were admitted as emergency, we expect a high quality of care looked after by a team with the appropriate infrastructure for good diagnosis, preoperative management, expert surgery, and good post-operative care. And these patients present often with some of the most difficult and challenging problems that we have to cope with. And it's only with the breadth of experience in those various presentations and the ability to cope with not only the clinical features, but also the interpretation of the radiology, CT scans, etc., that I think the surgeon on call in those situations is the individual who's used to working with abdominal problems and can address those issues. I don't think a CT, just looking at that, is enough, and I know of some areas where patients are being admitted through A&E, just have a CT, and that doesn't give a diagnosis, they're being sent home. That's inappropriate. And I think it's the specialist general surgeon who understands the issues, who can manage the quality of care under those circumstances. Many of you will know that we've had, over the last 15 months or so, a significant debate about what is generalism, what is specialism, and how we should take it forward, particularly in our own subject of general surgery. This debate has been stimulating, and has been actually some of the basis to today's discussion. But I'll take you back a few years when the combined consensus statement from the then presidents of August, ACP and ALS, defined in general GI surgery or general surgery as such three beasts, if you will. There was a super specialist, the one who does the very complex procedures. The bottom end, there was the generalist, the individual who works in the rural environment, who has to cope with most things. And indeed, you will see in the curriculum that not only do we have the breadth of general surgery, but under the generalist with the remote and rural, there's gynecology, ophthalmology, and neurology. That's not what we're arguing about. What we're arguing about is the middle group. That is the general surgeon who's gone through appropriate training, who has developed the skills to cope with the majority of what comes through the front door, and in addition has begun to develop their skills in their area of subspecialist interest, be it upper or lower gastrointestinal surgery. They are specialists, but they have a breadth of knowledge in the general aspect of abdominal problems. And this is highlighted by this, which is the list of jobs that were advertised during last year for over a 6-month period, and you will see there's a handful of the very complex specialists. The vast majority of posts that our hospitals need have a general interest with an interest in a subspecialty. It's this definition of the difference between a generalist and a subspecialist which I think is crucial, and I think an awful lot of what we're discussing is based upon terminology. Those of us who've developed a specialist practice have done so over a large number of years, having built on the breadth of our general GI training. We weren't a specialist on day one of walking into our consultant job. We were designed as a consultant general surgeon with an interest, and we've become a specialist, so we've developed those skills over that time. And I think that also fits in with what happens in emergency surgery. We develop the skills of approaching the more difficult problems. They do need some support in the early days, and it's a definition issue And I think that's something where we've had issues on the debate so far. I'm going to digress a little onto training because of my background from the SAC, because I think this is crucial for the next generation. In fact, will form the way in which we take this whole discussion forward. And it's really depending on the definition of the end product of training. The definition of the end product of training at the moment is a combination of things. It's an individual who's competent to manage unselected emergencies, and it's an individual who's competent to manage the breadth of a special interest. Now, latterly in the SAC, we've had some difficulty with people coming through to the application for CCT who don't quite meet both of those. We've also had some information through from trainee surveys where they are worried that they're not competent to take on the task that they're expected to do. In upper GI, for example, 75% of trainees felt they wanted to do a fellowship, and 90% felt they were inadequately ready to go on to become an upper GI consultant surgeon. There's this issue of experience and competence. And as we heard yesterday, we've got to go above competence in emergency surgery to strive for excellence, particularly in these most difficult group of patients. And the experience issue is a difficult one. We have a curriculum that is competence-based, but it's the ability to cope under the situations that you find yourself as an emergency with the experience. And we've got data suggesting that the experience trainees are getting from their logbooks, this is taken from a review of the consolidation sheets of trainees who got their CCT in 2010 and 2011. We've deliberately set the median as opposed to the mean, and have deliberately looked at the first quartile to show the level of experience. And then we're going to begin to use this information to set the benchmark for which individual trainees should be achieving. The bottom line is the survey that ASIT contributed to this study, because they had access to more electronic versions of the logbook. And you will see the spread of the procedures in emergency practice that all trainees have achieved, and particularly the GI trainees. And those, of course, are the ones who will be doing most of the abdominal emergency surgery. So the breadth of training has got some issues. And that's why I think that we should be moving to ensure that through training we can produce people who are ready to take on the breadth of the emergency practice. We've also got evidence that trainees are concerned, or trainees' experiences are not what they should be getting. We've had evidence of people who have gone into posts who have done well in their elective work, but have struggled in their emergency practice. The ability to think laterally has meant life has been difficult. And indeed, some of these individuals have been suspended temporarily. And I think we've got to build into this the mentorship from the emergency point of view. We've also got trainees' perceptions of what they're going to be doing. In the recent intercollegiate exam, one of the questions was, how do you manage a patient who's got a second bout of cholecystitis who comes in with a tinge of jaundice? And the colorectal trainee said, I will pass it on to my HPB colleague. That trainee did not do particularly well, because that's not what we want. I think the pendulum has gone too far towards the subspecialty route. We need to redress the balance between the subspecialty activity, which is all there and is there to be developed as one's career progresses, and the ability in training to produce someone who's got the general background to cope with the majority, upwards of 80% of everything that comes through the front door on a 24/7 basis. That's why I think the perceptions need to be changed. And we have to cope with service configuration changes. The vast majority of what we're talking about are abdominal problems. And indeed, those of you who work in emergency services, you will be having a slightly greater burden potentially, because the vascular specialty has now occurred, and the majority of breast surgeons are dropping off the general surgery rota. So it's those who are doing all of the abdominal work. We live in a world of outcomes, and if you look at the outcomes for emergency general surgery, it does not make very good reading. Yesterday afternoon, we had all the data from Mike Goff from CPOD, showing the poor results of emergency laparotomy in the LD group, the poor results of people coming in at weekends. We don't have simply sufficient surgeons to cope with, in every hospital, I don't think, specific subspecialty rotas. It has worked in Edinburgh, it has worked in Sheffield, and there are other centres looking at this. But the current configuration means we can't do it. Now, it may be that you could configure two relatively nearby hospitals, but I think there will be lots of other political issues to prevent that. We've also got to set the scope and standards for what we expect of our emergency surgery practice, because the trusts will be very conscious of this, looking at the risk management from their point of view. And that's why that document that Ian put out yesterday for emergency general surgery is so important, because it guides the way in which we should develop the general surgical practice for coping with the emergency service. So in conclusion, Mr. President, we have a problem. We must do better. We know that commissioners are going to be expecting decent results, and they will put it down to the trusts, and they, of course, will be under pressure, not only financially if they don't meet those targets, but also potentially significantly financially from the risk management point of view. We should be acting as the leaders to demonstrate what the scope and practice of emergency general surgery should be, that we should define what everybody should learn. Now, it doesn't mean that everybody should be doing absolutely everything, and there should be appropriate management, resuscitation, forwarding as necessary. But the example of the case I cited of the colorectal trainee walking away from a cholecystitis, no, we've got to make sure we teach trainees. They don't have to do, or indeed, established consultants, they don't have to do a cholecystectomy on every case of acute cholecystitis or nasty gangrenous gallbladder. You can cope with it in other ways, and those are the sort of things we should be promoting. And I think the general GI surgeons we propose ticks all the boxes. Thank you very much.
Now, I was remiss in my introduction because I didn't introduce Nigel. I don't know why. Nigel Scott's kindly agreed to oppose the motion. Nigel Scott, as you know, is a consultant GI surgeon in Preston, interested in intestinal failure, current president of Association of Chiropractology. And he, like Bill, will speak for 10 minutes, and then we'll have a question and answer session for half an hour. So if you wish to start tweeting now, please do. There's lots of seats down here if people want to move down. There's plenty of space. Nigel, thank you very much.
Okay. Well, I'd like to start by saying I'm a colorectal surgeon who does emergency abdominal surgery. I don't see myself as a GI surgeon. This is the proposal. The only way to deliver emergency surgical services is the creation of the general GI surgeon. And I'm speaking to oppose this motion. Now, I'm not going to take you back very far. I'm going to take you back 1 week to make my case, because a week ago this afternoon, I was padding around a hospital about 30 miles north of here with 3 sheets of paper that looked something like this. Because I think when we talk about emergency surgery, we've got to get some reality into the discussion. And drilling down into the sheet that I was walking around with, this is what I had a week ago this afternoon to think about. And it's a great mixture of things. Clearly, some of these conditions are GI conditions, but there are other things going on when you do emergency surgery. And it's for that reason that I think we should step back from it and recognise what the challenges are and whether they could be met by this creature called a general GI surgeon, presumably somebody who's doing a few lap gallbladders, a few lap right hemicolectomies and banding a few hemorrhoids. Is that the right person to be managing emergency abdominal surgery? Where's the diagnostic challenge? What have I learnt in the last 33 years of seeing acute abdomens? What have I learnt about the diagnostic challenge of the acute abdomen? I've learnt that you scan them, okay? That's what I've learnt. Okay, this is the answer to managing the acute surgical take. You find out what's going on. You scan anything that moves, and you scan a few things that don't move as well. Because that's what you find out what's going on. So that's almost an organisational thing. We all know that we're under this avalanche of abdominal pain. We scan the patients to find out what's going on. Relatively few of these patients are actually going to have an abdominal operation. Once I know what's going on and I've got the scan and it's been read by a proper GI radiologist, relatively few of these patients are going to need a laparotomy. And in fact, if you stand back and look at the emergency practice, the number needed to treat or laparotomize is something like 20 to 1. We go through about 20 people before we find one person who needs a laparotomy. This is the technical challenge of emergency surgery or emergency abdominal surgery. And when you finally come down to what we do, I wouldn't send anybody jaundice to my hepatobiliary colleague. I'd send him for an ERCP. That's how we do emergency surgery. We triage patients for a whole set of other people who are actually doing the intervention, who are doing ERCP for jaundice, who are stenting large bowel obstruction, who are embolizing bleeders. Quite a lot of the stuff we're doing now is not actually going near a surgeon. I have to recognize the problem. I have to get it to the person who can do the intervention. And it comes down to the fact that actually more and more abdominal surgery is contracting into maybe 4 or 5 procedures. Appendicectomy, perforated ulcer and Hartmann's for sepsis control, and doing adhesion obstruction or intestinal obstruction from some cause. There's not a huge technical challenge in terms of the number of procedures that we do, although I accept that the procedures can be very difficult because of the comorbidity and the illness the patient brings with them. And if we go to that other great bogeyman of emergency surgery, which is trauma, I've seen the stabbed IVC, I've seen the ruptured liver, I've seen the ruptured spleen. None of that is going to be helped by a guy who's knocking about in the daytime doing lap gallbladders, lap cholecystectomies, banding hemorrhoids. What we need to recognise, and what in fact is recognised in this document, Summary 1.8, is that emergency abdominal surgery is a distinct practice in its own right. This is not something to add on to general GI surgery. We should recognise emergency abdominal surgery as something that we train in, we credential in, and crucially after CCT, we keep updating in to keep our skills up to date. So that's my first reason for opposing the general GI surgeon as being the answer to emergency abdominal surgery. I've got 2 more reasons that I'd like to give you before I finish. What's this general GI surgeon going to do with colorectal conditions? Maybe the painful bottom. That seems a pretty easy thing to manage. Fissures, not a big deal. What happens about these girls that we see that have just delivered a baby and have a painful bottom with a fissure? Is that something that the general GI surgeon is going to inject with Botox, do a sphincterotomy, get some physiology done? I don't really know, because unless you've got a background in disease management, I would put it to you that in the elective management of colorectal conditions, you really can't give a useful opinion. You've got to know about disease. Surgery is disease management. It's not doing procedures. When it comes to rectal cancer, yes, we know that we image it, but how does a general GI guy know whether it's a local excision, what to do with complete response after chemoradiotherapy, how to do a low resection, how to do an APR? Now you say, he's not going to do rectal cancer, he's just going to do colonic cancer. So is he going to stop 15 centimetres from the anal margin or 20 centimetres from the anal margin? If he's given one of these cases from bowel screening, a polyp cancer, SM3 in the right colon, what does the general GI surgeon do? I accept he can do a right hemicolectomy, but the problem with the concept of the general GI surgeon is there's no training in disease management and judging which patient is the right patient to get the right operation. A general GI surgeon cannot function in elective colorectal practice. My last point is this. I don't think there's a problem. If you look at, and we're not going to bandy figures around here, but this is 33 newly appointed consultant colorectal surgeons asked to give us an idea, the Association of Coloproctology, as to what their median experience was at appointment. This is what it is. They've trained in rectal cancer, they've trained in proctology, they've trained in functional bowel disease, and they've trained in emergency abdominal surgery. They've got 150 emergency laparotomies under their name. We're actually producing right now, right today, there must be some newly appointed people in this audience who have got their training done, certainly in colorectal surgery, in terms of what we need when they come out, which is getting into the cancer MDT, dealing with difficult bottoms in the clinic, and assessing functional bowel disease and intervening with functional bowel disease. And then, when they have the need to, they get involved in emergency abdominal surgery. And when we ask people who are newly appointed, 2007 to 2012, did your training prepare you for your elective colorectal experience and for your emergency abdominal surgery? They say yes. For these three reasons, that the general GI surgeon is not the answer to emergency abdominal surgery, that the general GI surgeon cannot function in elective colorectal disease, and the general GI surgeon is not going to be the answer to what we're doing. I want you to oppose this motion. I don't want to resurrect the general GI surgeon. I want to let Lazarus lie, and I want you to vote against this motion. Thank you very much.
Very clearly put, as always, Nigel. Could I ask the four panel members to come up to the panel, please? Could I just start off the questioning just by putting one point that Nigel made there to the panel? You referred to the management of a patient with a polyp cancer detected on screening. I would put it to you, Nigel, that that's not what we're debating here, because that would go to a dedicated elective colorectal surgeon.
No, I disagree. I think the view that's being put forward, which is a mistake in surgery, is it's all about the ability to do the procedure. And although the procedure is a right hemicolectomy, what I'm arguing for elective practice is we need somebody who's trained in making the decision about whether or not a patient has an operation. I don't believe a general GI surgeon, although I've got a very poor view of what that person would look like, has a background in disease management for elective colorectal conditions.
Bill, do you want to comment on that?
I think that it is back to what I was making the point about definition. I don't have a problem at all with what Nigel is saying from the point of view of the elective practice, because the individuals who wish to pursue that line of work will be going through working with MDTs and what have you. My point is the issue about the individual who is taking care of what is the emergency practice, not the elective practice. You won't, in the emergency practice, I doubt, have somebody who's got an SM3 right colon cancer. But you've got to be in a position to cope with the patient who's got the obstructive right colon cancer. Now, it may be that that can be managed and then referred on to the next day. But you can get this problem, and I think it was Dennis Wilkins pointed out in his article a couple of years ago, you're at risk of patients being transferred back and forth and no continuity of care. And I think patients just don't like that.
Okay, there's loads of questions here, so let me start picking these off. Will the European Working Time Directive drive emergency surgery to become a consultant-only activity? From Stephen Wigmore. So I'll just repeat that. Will EWTR drive emergency surgery to become a consultant-only activity? Perhaps we'll ask John and Mike to comment.
I think the answer to that one, you could almost leave out the bit about EWTR, couldn't you? Because emergency surgery is the most difficult of all, and it probably requires somebody with expertise in emergency surgery to deal with emergencies, irrespective of EWTR. So I don't think EWTR per se will drive that, but I think there is a need to develop seriously qualified emergency surgeons. So I'm not talking about a general GI surgeon, I'm talking about an expert in the field of emergencies, like they have in the United States.
John?
Yeah, well, I think there's been a trend anyway, regardless of the EWTD, for the service to be either consultant-led or consultant-delivered. I don't think the hours have really had a bearing on that.
Okay. Let me ask another question from here. Are we moving towards an emergency room surgeon speciality in the UK? If not, why not? Magdalena Kincaid. Are we moving towards an emergency room surgeon speciality? Not quite sure what that means. Does Magdalena Kincaid want to explain? Perhaps it's limited by the number of characters when you tweet. You know, I'm an expert on this. You can only use 140 characters. Who can answer that? Okay, I'll ask another one. Is there some confusion here? It's about the need for an emergency general surgery, really, isn't it, rather than GI? I think that's a sound point. Is it emergency general surgeon as opposed to GI general surgeon?
I think it is, actually, because there are issues which, for example, we have a problem with paediatrics, that in there's a significant number of people will be seeing children with emergencies despite some of the changes occurred. We had a recent approach from a colleague, I think not that far from here, over acute scrotal problems, where the urologists, registrars were on call occasionally from home, and it was down to the general surgical team to pick this up. 17 or 18% of acute general surgery emergencies in the old days were urological. And I think it is probably a bit more than that. I've shown you the limited experience that everyone's getting in trauma, and we live in a dangerous world, and I think it's one of the things we're trying to address within the curriculum of having what's being termed surgery of civilian conflict. And it's having those skills to cope with what is going to come through the front door. And I think it's the ability. I appreciate Nigel's point about the ratio of operations, the number of cases. It's the ability to know when to do something and particularly when not to do something, which I think is crucial. And that comes with experience and the issue of the individual who's got that breadth of experience in emergency service.
Nigel?
I mean, it's wrong to polarise this too much black and white, okay, but that's exactly what I'm going to do. Because the real issue is, I think, as I've put it, is that we're faced with a huge amount of work. This is not sitting around four urgencies and trying to decide who's wrong or not. Scanning is the way forward. I'm quite sure about that. That although there's loads of anecdotes and people look a bit sniffy about it, it definitely sorts out who does and who doesn't need something doing to them as a rule. My view of this is that the people we produce at the moment at CCT, or the people I see in the northwest of England, can handle the emergency take. The problem that I would acknowledge with subspecialisation is after CCT, those of us who are in our specialty practice should update quite regularly with the other specialty, and that we should also have trauma updates. You know, that's what I think is the answer. It's not, to me, at CCT. It's after CCT that we need to look at emergency provision. Okay,
so let's take that point, which I think most of us would agree with, that you develop your subspecialty skills after CCT in whichever...
That's not my point. My point is that you're a subspecialist at CCT. You keep updated as an emergency surgeon after CCT.
Okay, but you'd agree that somebody at CCT level, as at any stage, still requires further training to develop their subspecialty interest?
I agree I need further training. But what I'm trying to say is the guy who comes at CCT, who's got that kind of logbook and joins our colorectal MTT, can get involved day one in doing curative colorectal cancer resections, and that's what we need.
Okay.
John, can I just say that I think that's fine, because that's the elective side of things. I will take, as you probably appreciate, the polarised view from what Nigel is saying, and I think this is the crux of this discussion, is that Nigel is saying that at CCT you've got majority of your skills for the subspecialty activity and you can be termed a specialist. I have my reservations about that. I think we've got the situation in training at the moment to allow people to have the breadth of general surgery, we recently had a meeting of the Surgical Forum where general was actually considered pejorative, and I think we should, accepting what I said about paediatrics and urology, it's abdominal problems, abdominal surgery, and that's where I think the skills should be there by the end of training to cope with the vast majority of what comes in. So that's the difference.
Can I just say that one of the reasons this debate has arisen in the past year or two is not because there's a desire by anybody sitting up this end to change what's happening. It's a recognition that the world is changing. So I just put it to the four panellists. The world is changing because of ours. It's changing because of lifestyle. So whilst you've put up very good logbook data, there's a strong possibility that the current tranche of trainees will not have the opportunity to do so many operations in the future. And therefore, at the time they get a CCT, they will not be so experienced. That's not their fault, that's the situation. So that's point one, is experience. Point two is the biggest clinical service in this country is emergency general surgery. In terms of numbers of patients. And that's what the chief executives are going to focus on and the commissioning groups are going to focus on as of next April. And thirdly, we know for a fact that the standards of care with emergency surgery are poor, they're variable, and therefore we as a profession should be addressing matters to change that. So because the current tranche of trainees will not be what happened in the past, and because the chief executives will be dominant, will be dictated to by what they have to provide in their hospitals, and because of commissioning groups, it means that the environment is going to change. Can I ask the panel to comment on that?
Can I take that one first, John?
Yeah.
If I may. The facts speak for themselves. You've just said it. We saw yesterday that the figures from emergency surgery, they're nothing short of appalling, really, compared to where they should be. And yet, we're having a suggestion today as the topic of the debate. The motion is pleading for what I would call a retrograde step to the general GI surgeon, when actually it's staring us in the face. It's blindingly obvious that what we need to do is develop emergency surgical services as a new specialty. They have this already in the United States. I said this yesterday, and what happens in the US comes here 10 years later. We shouldn't be fuddling around and trying to mismanage something rather badly. We should start from here with a fresh sheet of paper and say, what is it going to take to provide expertise? That's not just somebody who's had a bit of emergencies added on to their elective. It's somebody who wants to do emergency surgery as a career. Start from go, get a curriculum, get a syllabus, train them up, get expertise initially imported if necessary from America, but find out what they're doing. They have websites available already. They have associations of emergency surgeons. Their next meeting, you might like to know, is in Hawaii. I'm seriously thinking of taking it up as a new career. But it's out there already. We shouldn't be having this debate. The topic is wrong. We should be looking at a new animal, and that would be my solution.
Somebody's tweeted here. You've been tweeted, Mike. That's a new experience for you. Well, I'm being presumptuous. Should trainees have an emergency surgery module to ensure enough experience? For example, 6 months doing only emergency surgery. Andrew Beamish.
Well, I suppose at the moment the answer is yes, but in the longer term I would be looking, as I said, to providing a different animal, and somebody who's got an interest in emergency.
Okay, so you want a different animal. Bill, John, Nigel?
It's just to challenge Mike on that if you're going to have a separate specialty, the numbers of individuals that will go into that, contrasting with the totality, the number of people we need to run the emergency general surgery service in this country. The American system set out because those as I understand it, those states which were geographically remote and there was long journeys between towns to sizable hospitals meant they had to have some form of surgical service in those more remote areas. And if we're arguing for a specialty in emergency general surgery, you're going to have the sufficient number in that to cover all acute receiving hospitals.
May I just respond to that?
In a second, Mike. Let me just read another comment here from the audience. General GI surgeon versus colorectal surgeon, that's not really the debate, but the question here is, so what does this is from Andrew Beggs. How many upper GI surgeons would feel happy doing a Hartmann's, and how many lower GI surgeons a subtotal gastrectomy for a perforated gastric ulcer? Andrew Beggs. Now that question instantly is relevant to what Bill's just said about provision of surgical services when you're away from a large hospital. Does people want to comment on that?
Could I respond? I mean, the Hartmann's thing, I honestly don't think is a problem, because I took over that sheet from my newly appointed upper GI colleague who did the Hartmann's operation. I don't see that as a problem. I think gastrectomy is a problem, all right? But I think it's a problem for everybody, because none of us, including upper GI biliary type surgeons, are doing gastrectomy. That is quite definitely a problem for all of us, and I think that's why I need to try and work with my esophageal gastric resection colleagues twice a year to see what they're doing in terms of techniques for gastrectomy. That's how we should be addressing the gaps, and I do think gastrectomy is a gap, but I would put it to you, it's a gap for a lot of people, including people that stylise themselves as upper GI, but are in fact biliary surgeons.
Yes, and it's now extremely uncommon. So, and similarly with upper GI bleeding, most of us would manage that with angiography in the first instance. You're not talking about doing major resections. Sanjay Chowdhury has written here, surely the job market pressures will decide the need for emergency surgeons on cheaper pay scales. That didn't go down very well, did it? I didn't ask the question. John, you speak.
I think people have short memories. We used to have emergency surgeons. Many of the smaller hospitals had surgeons who worked in the A&E departments, and they did emergency surgery. That was abandoned because unless the hospitals were very large, they didn't have sufficient work to maintain their skill levels. And they ended up doing ingrown toenails and minor surgery. And the specialty was abandoned. So I don't think we should be going back to that. I think there is a confusion here between elective work and emergency work. Bill and I are not talking about the elective side of things. We're talking about training people to do those things that have to be done during the night or at a time when a subspecialist is not available. I don't think anybody is suggesting that someone does a low anterior section at 3 in the morning or a Whipple's procedure.
I think that's a point worthy of emphasis. You are not talking about elective surgery.
You know, we're talking about doing those things that are absolutely essential during the middle of the night. And if you stop to think about it, the list is a small list. It's not a long list. And I think it's perfectly feasible to train people to do the generality of emergency GI surgery. It's not rocket science.
Do you think we should evolve towards a system, because future pensions are such that people are going to have to work till they're 67 or 69 or something ludicrous? Does that mean that people after 50 or 55 should come off the on-call rota? In which case, who does the on-call? Mike?
I'm not sure which of those questions you want me to answer, but in turn, first of all, to explain a little bit about Bill's comments, you're not going to have these emergency surgeons in huge numbers because, as Nigel's already explained, the well-trained expert, if you like, in colorectal surgery can deal with emergencies. So we're only going to need a small number of these to fill the gaps. Now, that's where EWTR might come into it, to determine, the chief executives will have to determine how many people you're going to need. But that's where I would see the emergency surgeons fitting in. Now, in terms of workload, I actually have one of my trainees is an emergency consultant surgeon now. He has a very full workload and he's enjoying it very much. And it's all to do with what you put into it. He will cover the range, the full range of emergencies because he's so trained to do. And although he might even do a gastrectomy, I'm not really sure, but he has had that experience in his training to do so. None of us do many gastrectomies these days. I can't remember the last time I did one.
Not that many. Someone has tweeted here, if we don't have enough emergency surgeons, Andrew begs, should all emergency surgery be centralised in large centres? Now, we had David Nicholson here yesterday, and whether we like it or not, there's going to be significant reconfiguration. So is that one way around this problem?
I would submit that it's an almost inevitable solution that's going to happen. You'll hear more about that when I speak, but in truth, it is inevitable.
I think in all of this we're forgetting one important person, that's the patient, and what society wants. I don't think society wants to spend hours in a car travelling, for miles to go to a particular centre. I think people want and expect a good service delivered in their locality. Now, I'm not talking about the old two-man unit. I'm talking about, the typical small to medium DGH in which the bulk of the work is currently delivered. You cannot put all those people in a car and transfer them to the big smoke. Those of you who are at the green surgery session this morning will have heard that almost 20% of our carbon footprint currently goes in transport. We can't add to that anymore. We have to come up with a sensible solution to deliver a high-quality service close to where the patient lives.
Okay, we're coming up to 10 minutes before the end of the session, so I'm going to ask the seconders to speak, but is there any burning issues from the floor? Does anyone want to stand up and vent their spleen? No? No one wants to vent their spleen. In which case, could I ask you, John, please, to reply first?
I think there should be some slides. Allegedly. Can we get the slides on? Oh, here we are. Right. I think the motion is fairly clear-cut, and really it's a no-brainer. You know, we're supposed to be delivering a service that the patients want, not what we want, and we have to respond to their needs, not get them to respond to our needs. So I think this motion is a no-brainer. Now, Nigel has said in the past that, you know, everybody should be treated by an expert, and we would all agree on that. There's no disagreement. The big question is, how do you actually bring that about? Now, the view of Nigel and Mike would be that, you know, it's fairly clear-cut. The specialists deal with the emergencies in their field. The perforated diverticulitis at 4 in the morning will be operated on by a coloproctologist. The GI bleed that the gastroenterologist couldn't deal with will be operated on by an upper GI surgeon. It's simple, so what's the argument? Well, the argument is we don't live in a world that works like that. Most of the work in the UK and Ireland is actually delivered in small to medium DGHs. We don't all live in the rarefied atmosphere of the big smoke, where we have multiple tiered rotas of breast surgeons on call. Well, maybe they don't actually do on call. Upper GI surgeons, vascular surgeons, coloproctologists. Most of us live in work in hospitals where you may have a much smaller number of surgeons on, so you do not have this luxury that we keep hearing about. And there's clearly far too much work to centralise. Now, we're not talking about some small, non-viable hospital. We're talking about a hospital that maybe serves a population of 500,000. They will often not be big enough and have enough surgeons to have multiple rotas. So you have to try and create the local expertise to deal with the emergency work. And I think there's been some confusion about what we're talking about here. We're talking about emergency work, not elective work. Look at the things that have to go to theatre out of hours. It's not an exhaustive list. You know, a lot of things can be babysat until the following day and dealt with in a more controlled situation. But every now and again, you have to take somebody to theatre and do something. And, you know, as I say, it's not a long list. And it should well be within the realms of surgical training to make sure that we can produce a general GI surgeon who can do these things out of hours. So I think it's fairly clear-cut. We simply don't have the resources to transport everybody to the big smoke. And those of you who have worked in some hospitals where you have had to transfer, for example, neurosurgical cases, burns cases, to a regional centre will have discovered that when you try to do it, there's never a bed. So it's a preposterous idea to suggest we centralise to that extent. It simply doesn't work. We have to try and create the expertise locally. And when you think of it, it's fairly simple. If you take a typical surgical trainee, give them enough training, it should be easy to produce one of these. Thank you.
That was disgraceful, John.
Well, this is a debate, so I haven't got any slides you'll be pleased to hear. But the hot topic isn't listed up there, the words, but it says the only way to deliver emergency surgical services is the creation of the general GI surgeon. Well, of course, the moment you write that, you say the only way, you have to dismiss every other possibility. So I want you to remember that when you're going to vote in favour of this motion, is that you are clearly so narrow-minded that you cannot possibly include any other options. If you find that you do have visibility outside on the radar, you cannot possibly vote in favour of this motion. It's very simple. But there are some reasons why you shouldn't vote in favour of the motion and you should oppose it. John's already alluded to the fact that it's there for the patients. If you take this to the extreme and you go right to the end of the food chain, the person that we're doing this for, trying to decide what's best, is the patient. Now, at the College of Surgeons, we have a very, very powerful and very wise body called the Patient Liaison Group. And I've spoken to them about this. And I've asked them for their opinion because that's what matters. That's what they represent patients. They speak in the House of Commons quite regularly in the select committees, and they know what they're talking about. They want clinical experts. And they want experts, the likes of which you've just seen 2 photographs up there, working in the elective side, but they also want it in the emergency side as well. They don't want a sort of general dog's body who's just trying to do his best and cover up and patch up, which is really what a general GI surgeon would end up being. That's not the right thing. We need experts. And the way to get to that, I will come to in just a moment. The second thing that you have to consider, which has been carefully washed over, nobody's really addressed it, is finance. Now, the health service was started on the 5th of July 1948, and the amount of money put in the first year was £11.4 billion and stayed there for the next year or so. But it has increased at a rate such that in the last year, up to the beginning of 2012, it was £110 billion. And what has actually happened is that that rate of increase, which has gone up each year steadily, is 2% greater than the increase in the GDP or the total amount of public spending. And those lines are going to cross this year. So basically what that means, if you want it in simple terms, is we've run out of money. We haven't got the money to run the health service the way it has been up to now. Something's got to give. Now, there are 2 options. You either tax people another 5 or 10%. No government in their right mind is going to do that because it's political suicide. Or you have to chop. You've got to cut some money out. That's what's happening now. 20 billion this year, probably more next year. Something's got to go. Now, the result of that will be 3 things. Reconfiguration. It's already happened in Northern Ireland. You've seen it already, hospitals being closed and shifted together and so on. We've seen some of it in the UK already. Rationalisation, for that read cutbacks or cutting something somewhere. And centralisation. It will happen. Centralisation will happen for good reasons. Not necessarily the emergencies, it's really the elective work. We know in colorectal, for example, that people who do a lot of colorectal cancer get better results than those who don't. We have the figures and the stats to prove it. We know that somebody who does more than 8 ileoanal pouches a year gets much better short and long-term results than somebody who's doing less than 8 a year. It's inevitable that we will get centralisation of resources, and in so doing, with the rationalisation programme and the reconfiguration, we are going to get those bigger hospitals. It is inevitable. There will be some big district generals out somewhere in the periphery, and they will have to be serviced. And the way they'll do it is by what I see as the future, which is the emergency surgeon. And these will be specially trained people who will be able to deal with the emergencies. And as Nigel points out, it's only 1 in 20 of the things that come in the door that you actually have to operate on. The rest is decision-making. And if you spend a 7 or 8 year period training in that subject, you will learn everything about it. The Americans have showed us this. And also, we have to learn from the military. If you get something that's beyond your capability, you patch it up quick, you keep them alive, and you transfer them. And their results are so much better than we've ever achieved in this country. We've got to learn from that. There is a reason to stop, think, patch somebody up, and move them on to the centre where everything is available. Emergency surgeons will be able to do that. I've already mentioned about the websites and things. You can look these up in the United States. They're fully functional. They have training programs. They have residencies. They have proper programs. And we have to look to this. We really do have to look to this for the future. I would also like to put a real hand grenade into this as well. And this is my view. I'm not representing the college or any association. This is my view. But in the next 50 years, we're going to have a completely new training paradigm shift. Because the way I see it is everything's getting a little bit blurred at the edges. You know, when you have a problem with a bleed, is it the surgeon who deals with it? Is it the radiologist? Is it an endoscopist? Everybody's chipping in, and we need people who are going to be trained not so much in anatomical silos, but in disease projects. So you might have, for example, pelvic surgeons. There's a lot of commonality. There's a lot of interventionalists that will be working on that as well. The vascular surgeons have already done it. We don't have what I used to call a vascular surgeon anymore. They're vascular interventional surgeons or radiologists. They're all part of a group. And I think it's something we really need to take on board, that we need to train people by disease specificity. There will be difficulties, protectionism, self-interest, tradition, all those sort of things, but we will have to overcome those because things are going to change. We've already heard of an operation this evening, the highly selective ergotomy. I used to love doing that, but that went. There will be other operations that will go as we progress in medicine. When Crohn's becomes treated by antibacterials and that sort of thing, things will disappear gradually, but we will then have the ability to meld everything else that's available outside of the anatomical silos into disease areas, and we will have clinicians. There may not be called surgeons and radiologists and everything in the future. We may have a different term for them, but they will be disease-specified clinicians. And to do that, we probably have to think right outside the box. We're going to have a 3-year training program for those who want the basics, who want to run, and then go into a specialty such as emergency surgery. That'll be common STEM training. There will then be a broad-based training for those who want to develop into something in that disease-specific specialty. And then the highly trained one doing 8 or maybe more years to become really top class in that field. That is going to be the future. So, can we vote in favour of the only way to deliver emergency surgery? Well, I don't think we can, because I was looking through this booklet recently, this afternoon. It's called Emergency General Surgery. It's written by the Association of Surgeons of Great Britain and Ireland. I notice it's on the back here. And on page 4, item 1.5, it says, several differing models of care are being described. It is clear that one model will not fit every hospital. It's in your book, John, in case you weren't sure. So if you've read this book, I would just point out that you cannot vote in favour of this motion.
Thank you very much, Mike. You can see that one of Mr. Parker's attributes is not timekeeping, but never mind. He's always entertaining. Right, all those in favour of this motion, that the only way to deliver emergency surgical services is the creation of a general GI surgeon. If you'd raise your hands, please. It's just the same as before. and those who are opposed to the motion. So that clearly the motion is defeated. So I'd like to thank the speakers. It's been very good, very entertaining. I know there are lots of issues we haven't discussed, and there always will be, but it airs the debate.